السلام عليكم ورحمة الله وبركاته. معكم تركي هلال الحساني، جامعة أم القرى، سنة خامسة طب. راح نأخر الابتداء إلى تقريبا الساعة 7:20 بس عشان يجتمعون الناس، ونبدأ إن شاء الله الميتنج.
طيب، السلام عليكم ورحمة الله. I think we should start now. So, welcome everyone. My name is Ahmed Magadmi. I'm an R3 emergency medical resident from National Guard Hospital in Jeddah. Today we're going to talk about neurologic emergencies. So, the nervous system is absolutely fascinating, but it can be a little bit intimidating. So hopefully by the end of this presentation, you will be able to identify and approach the main neurological emergencies. We're going to focus on stroke and seizure, but we will also talk about altered mental status, headache, dizziness, and vertigo. And if we have time, we're going to go over spinal cord disorders as well. So we will begin by refreshing our memories about the anatomy of the nervous system. So the nervous system coordinates the actions of complex organisms via the transmission of electrochemical signals. I have a bit of issues.
دكتور، السلام عليكم، سامعني؟
I apologize for this. Okay, so we're back online. So as we said, the nervous system coordinates the actions of complex organisms via the transmission of electrochemical signals. Now, these signals are transmitted by a specialized network of cells called the neurons. So the nervous system can be divided into two main parts. We have the central nervous system, which is composed of the brain and the spinal cord, and we have the peripheral nervous system composed of the cranial nerves, spinal nerves, and peripheral nerves. Also, our central nervous system is protected by three layers. We have the first layer, which is immediately above the brain. It's called the pia mater. Then above the pia mater, we have another layer known as the arachnoid mater. And then above the arachnoid mater and immediately below the skull, we have the dura mater. So anything above the dura mater, any pathology above the dura mater is known as epidural. Any pathology below the dura mater is subdural. Any pathology below the arachnoid mater is known as subarachnoid. If we look at the brain, we know that we have multiple lobes. We have the frontal lobe, we have the temporal lobe, parietal lobe, occipital lobe, and the cerebellum. And each of them perform different functions. If we take a cross-section of the brain, we will see that we have two major parts. We have the gray matter, we have the white matter. So the white matter is composed of bundles of myelinated axons, which connect the various parts of the gray matter, while the gray matter is composed of neuronal cells as well as unmyelinated nerve fibers that function as the regions of the brain where information is processed. So basically, the gray matter is the processor, and the white matter is just to connect different parts of the gray matter together. So now that we refreshed our memories regarding the anatomy of the nervous system, let's begin our first emergency, which is stroke. So let's talk about the stroke. So we're going to go over the background, types, clinical features, differential diagnosis of weakness, evaluation, management, and finally a general approach. So what's the definition of a stroke? So stroke is basically a vascular injury that reduces the cerebral blood flow to a specific region of the brain, causing neuro impairment. So in a sense, a stroke is basically a brain attack. So like we have a heart attack in which some parts of the heart receive less blood flow and therefore die, the brain also can develop a brain attack. If the vascular supply to a certain area of the brain is compromised and the patient developed neuro impairment, we call this a stroke. Statistically, it is the fifth leading cause of death. Every year, around 800,000 people experience a stroke, which is almost one stroke every 40 seconds. Now, these statistics are from the US. I couldn't find anything locally here. So what are the types of stroke? The strokes can be classified into two main categories. It could be ischemic or it could be hemorrhagic. So hopefully 80% of our strokes are ischemic strokes, or how the way we describe it to our patients in Arabic, we tell them naqs. So 85% of our strokes are ischemic strokes. And ischemic strokes are further classified in multiple categories as well. So the first one is large vessel occlusion, which account for 35% of all strokes. Large vessels, we're talking mainly about the carotid artery system. It's more common in men than in women, and more common in whites than in African. The second type, which is cardioembolic, it accounts for 25% of all strokes. When we say cardioembolic, we're mainly talking about a thrombus within the heart that for some reason showered all the way up to the brain. So this could be due to an atrial fibrillation. Sometimes it's in the carotid system, so carotid stenosis with plaque formation. And sometimes it's a mural thrombi secondary to myocardial infarction. 20% of our strokes are lacunar infarctions. When we say lacunar, we basically mean small vessel disease. So intracerebral arteries, like the middle cerebral artery. Africans are more affected than whites. People with hypertension, diabetes, sickle cell, protein C deficiency, and polycythemia are at risk of developing lacunar infarctions. Now, the second type of strokes are hemorrhagic strokes. These are more devastating and more dangerous. They represent 15% of all strokes. And we can classify them into ICH, intracerebral hemorrhage, and SAH, subarachnoid hemorrhage. So intracerebral hemorrhage compromises 66% of all hemorrhagic strokes, or 10% of all strokes in general. And 30-day mortality approaches 50%. So the mortality is very high. Subarachnoid hemorrhage, on the other hand, it accounts 33% of all hemorrhagic strokes, or about 5% of all strokes in general, usually associated with a ruptured perianeurysm. Now, something else that we have to keep in mind is the terminology of TIA, transient ischemic attack. So basically, transient ischemic attack, it means, sorry. So basically, it means that we have a vascular injury in the brain causing neurological deficit that is completely resolved. So it's a transient episode without actual infarction. So you have someone who has history of neurodeficit that completely resolved. So what about the time window? So the way I remember it from medical school is that we were taught that if the resolution happened less than 24 hours, this is TIA. But if it was more than 24 hours, it is not TIA, it's a stroke. Now, this definition is completely wrong. So the new definition is tissue-based definition. What it means is the endpoint is biologic. يعني, if I encountered a patient who presented with 3 days history of weakness, but right now, like 2 hours before presentation, his weakness completely resolved. Can I call this TIA or not? It depends. So I do my neuroimaging, I do my advanced neuroimaging, and if there is no evidence of an acute infarction, it's a TIA, regardless of the time window. So again, the new definition of transient ischemic attack is tissue-based. So I have someone with weakness, the weakness completely resolved spontaneously without any intervention. I do my imaging. If there is no infarction, it's a TIA regardless of the time frame of the patient. Here we can see a simple photo of ischemic versus hemorrhagic stroke. So you can appreciate in an ischemic stroke, you have this area of hypodensity over the left side, while in a hemorrhagic stroke, you can appreciate the hyperdense area, the area in the middle. This is actually the blood. So blood on CT scan, it's hyperdense, it's white. So what about the clinical features? So the first thing that I want you to remember and to keep it in your mind is the mnemonic of FAST. So F, look at the face. Do you have facial drop or not? If you have facial drop, you should be concerned. Then the A, we're talking about the arms. That the patient has any lateralization, any weakness over the right or the left side? If so, you should be concerned as well. S for the speech. So when the patient talks, is he slurred or jumbled? يعني بيتكلم واضح ولا ملخبط? If the patient is slurred or jumbled, you should be concerned. Finally, the time. So time is brain. If you encountered someone like this patient outside of the hospital, someone with a facial drop, lateralization, slurred speech, then please call 911 immediately. So contact your EMS provider. But if you are in the hospital, then time is also of the essence. So you have to ask about the time frame of the symptoms. So there are a wrong way to ask about the onset of symptoms, and there is a right way to ask about it. So the wrong way is to say, when did the symptoms started? And the better way is to ask, when was the last time the patient was well? So why does this make a difference? So we know that the time window for stroke, for TPA, the golden hour for revascularization as per evidence, or sorry, as per guidelines, is 3 to 4.5 hours. So someone who presents within 3 to 4.5 hours are, as per guidelines, eligible for TPA. So how should I ask this? So a simple scenario is, if you are working in the emergency department, it's 12 p.m. So it's around noon, and you have this patient presenting with left-sided weakness, facial drop, and slurred speech. If you ask him, when did the symptoms start? He will tell you 2 hours ago. But if you ask him, when was the last time you were well? He will tell you maybe 7 hours ago. Why? Because he woke up at 4 a.m., he prayed, he was completely fine, then he went to sleep. And then he woke up 2 hours ago with this weakness. So the problem is we don't really know the time of the exact time of the stroke. So maybe the stroke happened at 5 a.m. when he was asleep, maybe at 6 a.m., maybe at 7. So you can't really tell. So such patient, we cannot really give TPA because, as we said, as per guidelines, the golden hour for TPA is 3 to 4.5 hours. Beyond that, it becomes more harmful than helpful. So again, I'm gonna say this in Arabic. لما يكون عندك مريض جاي left sided weakness, slurred speech, and facial drop, لا تسأل وتقول متى بدأت معك الأعراض. No. السؤال الصح إنك تقول متى آخر مرة أنت كنت كويس، لأنه كثير من الأحيان بتكون wake up stroke. So the patient went to sleep, he was fine, and then woke up with this weakness or this neurological deficit. So in such patient, we account the we consider the stroke not from the time he woke up, but actually from the time he went to sleep. So the stroke becomes from 2 hours, بدل 2 hours تصير 7 hours. So this is very important. Again, please, when you ask about the onset of symptoms, the correct question is, when did the symptoms start? So this, I put this slide just to emphasize the importance of keeping a wide index of suspicion. So usually when we think of a stroke, we think of the typical left-sided weakness, slurred speech, facial drop, which is the majority of cases actually, since the anterior cerebral artery and the middle cerebral artery, both of them, they cause contralateral weakness, facial drop, with or without aphasia, with or without urinary incontinence. But sometimes you have different parts of the brain that is subjected to a stroke. So for example, let's look at the vertebral artery. The vertebral artery, when there is a stroke involving the region of the vertebral artery, you will have someone presenting with vertigo, or nystagmus, or dysphagia, even diplopia. So keep in mind when you have someone complaining of vertigo or has a new onset diplopia or ataxia, it could be a vertebral artery stroke as well. Now, again, the majority of strokes are anterior and middle cerebral arteries, but keep in mind that there are different presentations of a stroke depending on the artery involved. So the differential diagnosis of weakness is extensive, and this is the aim of this slide. So yes, whenever you have someone with weakness, the way we think is critical, so we think of a stroke. But please don't forget hypoglycemia. So whenever you have someone presenting with left-sided weakness, with altered mental status, or with seizure, the first question that you should ask is, what's the patient's glucose? So please immediately do point of care glucose. Patients with hypoglycemia can present with typical symptoms of stroke. راح يجيك بلeft-sided weakness, slurred speech, facial drop. You will measure his RBS, you will find it 2 millimole, أو خلينا نقول تقريبا 50 milligram per deciliter. You give him dextrose 50%, 50 ml, he returns completely normal. So please, whenever you have someone with picture of stroke, think of hypoglycemia. So other differential diagnosis, it could be seizures, followed by Todd's paralysis. So some patients, they experience seizure, and the post-ictal state present in a form of weakness. We call this Todd's paralysis. Sometimes it's actually syncope, or something like hyponatremia, an infectious process like meningitis, encephalitis, hyperosmolar state, labyrinthitis, drug toxicity like lithium, phenytoin, or carbamazepine toxicity, or it could be Pill's palsy. So when you have someone with only facial manifestation, think about Pill's palsy. So how can you differentiate between Pill's palsy, which is a peripheral or lower motor neuron lesion, and a stroke, which is upper motor neuron lesion? So the simplest way to differentiate between stroke, a stroke and Pill's palsy, again, stroke, it's upper motor neuron, and Pill's palsy, it's lower motor neuron. So we remember that upper saves upper. So in patients with a stroke, you will have facial drop, but the upper part of the face will be okay. When you ask the patient to elevate the eyebrows or close their eyes, the upper part of the face is normal. The problem is with the lower part of the face. You will see dropping of the angle of the mouth, difficulty in whistling, or difficulties in puffing their cheeks. While in Pill's palsy, both the upper part and the lower part of the face will be involved. So you will have someone with facial drop, the mouth of the angle is dropped, but also flattening of the wrinkles of the forehead over the affected side. Now, again, it's very important to think the stroke and to keep stroke as the top differential diagnosis. to do your studies, to do your imaging, to do everything. But in the end, if it's a lower motor neuron affecting the 7th cranial nerve, it's Bell's palsy. Another differential diagnosis is complicated migraine, and migraine is very elusive. So sometimes migraine present with complete weakness. So how can I differentiate? Well, for someone who's presenting with his first migraine, it's almost, I'm not going to say impossible, but it's very difficult to judge. But for someone who's having this migraine over and over and over again, you can just ask the patient. So have this episode happened to you before? He will tell you yes. You will ask him, what did the physician tell you? He will tell you, the physician told me that I have migraine. So, and usually you're talking about younger patients, people around their 20s, their 30s, their current episode of headache with this weakness. So usually they are known migraine. You also have Meniere's disease, demyelinating diseases, conversion disorder, and transient global amnesia. Okay. So let's go over the evaluation. So again, any emergency, we always start A, B, C. Here we also have D, E, F, G. So A for airway, make sure that the patient's airway is patent, breathing normally, circulation, so obtain your vitals. What about D, E, F, G? So D, E, F, G stands for don't ever forget glucose. So again, please, when you have someone presenting with any neurological manifestations, please ask about the blood glucose level. So always obtain blood glucose level. You don't want to activate a stroke code for someone or even give thrombolytics for someone who's hypoglycemic. And it's a very easily reversible cause. So the patient is hypoglycemic, give him dextrose, case closed. Then we go with our history and examination. And again, in the history, one of the most important thing is the time window. And again, please, when you ask about the onset of symptoms, the correct question is, when was the last time the patient was well? Because in a lot of times it's a wake-up seizure. The patient is okay, he goes to sleep, he wakes up with this weakness. So we don't really know the time frame for the seizure, for the stroke. It could be immediately after he fell asleep, or it could be before sleeping or before waking up. So when you have someone like this, the time frame for the stroke is from the last time he was well. In examination, we're going to do a full neurological examination, and we're going to focus on the affected side. So after that, we're going to go with our labs. So again, the first thing you're going to do is point of care glucose. You're also going to do your CBC, your chemistry, your coagulation, and your troponin as well. So why is troponin important? Well, one of the explanation for this stroke and sometimes even seizure is actually a cardiac event. So especially with elderly patients. So this patient went into some sort of myocardial ischemia. The myocardial ischemia caused ventricular dysrhythmia, and the ventricular dysrhythmia compromised the blood supply to the brain. So please don't forget to order troponin for your elderly stroked patients. The second thing is to do an ECG. ECG is very important and very helpful. So in large intracerebral hemorrhage or stroke, we might see deep T wave inversion. We call this cerebral T wave. So when I do an ECG for someone like this and I see deeply inverted T wave, I get really concerned for a large stroke or even an intracerebral hemorrhage. Sometimes strokes causes prolonged QT or some ST segment changes. So what about our non-contrast HIT CT? So why am I doing the non-contrast CT? So if you look closely, you will find that the non-contrast HIT CT for ischemic stroke is only 42% sensitive, which means that if I did my non-contrast CT and I did not find any signs of ischemic stroke, I cannot rule it out. Usually in the first 24 hours, you cannot see signs of acute infarction. Yes, there are some signs, but the majority of patients do not experience any changes based on the non-contrast HIT CT in the first 24 hours. So why am I doing the non-contrast HIT CT? Basically, I'm doing the non-contrast HIT CT because I want to rule out the presence of bleeding. So, and this is the real killer here. So non-contrast HIT CT for intracerebral hemorrhage has a sensitivity of 95 to 100%, which means if I did my non-contrast HIT CT and there are no signs of bleeding, I can rule it out. But again, keep in mind that I cannot use the non-contrast HET CT to rule out ischemic stroke. And this is what we tell our patients. So when we do, when we have patient coming in with signs and symptoms of acute stroke, and we book the patient for CT, and the patient comes back and the CT is normal, we tell our patient and we tell the relatives of the patient انه حتى لو كانت الاشعه المقطعيه في اول 24 ساعه طبيعيه وما فيها اي علامات من علامات الجلطه، في النهايه تشخيص جلطة الدماغ بيكون حسب الأعراض، والأعراض اللي عند المريض ماشية مع الجلطة. ففي هذه الحالة بنقول لهم يحتاج تنويم ويحتاج أشعة مقطعية بعد 24 إلى 48 ساعة. Okay. Another reason we go with the non-contrast HET CT is to identify stroke mimics. So, for example, if I have a mass lesion or an abscess, so it's really difficult to tell the difference between a tumor and an abscess based on a non-contrast HET CT, but at least you can see the mass effect. You can see that there is something pushing everything in the brain to one side, and definitely the radiologist will suggest giving contrast to repeat the image and give contrast. So again, the aim of the non-contrast HET CT is basically to rule out ICH and to identify stroke mimics if possible. So other things that we might consider is to do CT angio of the brain and neck. We do this to check for large vessel occlusion, because if we have large vessel occlusion within the first 6 hours and sometimes up to 12 hours, there is the potential of thrombectomy, which is done by interventional radiology, and it's extremely useful. Also consider pregnancy test in a child, in a lady in a childbearing age. Consider doing chest X-ray, urine analysis if infection is suspected, and sometimes even LP if meningitis or encephalitis are suspected as well. And do your urine tox screen if ingestion is suspected. So what about the management? So again, we have three major entities. We have transient ischemic attack, in which the patient completely resolved. We have ischemic stroke, and we have hemorrhagic stroke. So for transient ischemic attack, keep in mind that even though the patient is completely normal right now, there is high risk of impending stroke. So we might need to repeat the CT as ischemic changes may not be present until more than 24 hours. And sometimes we even do carotid Doppler and echocardiogram as well as Holter if indicated. So how can I tell if the patient in front of me can be discharged home with a close neurology follow-up, or need to be admitted because he has high risk of impending stroke? So we use something called the ABCD2 score. So the ABD2 score, it estimates the risk of stroke after a suspected transient ischemic attack. So it takes into consideration the age of the patient, the blood pressure, the clinical features of TIA. هل كانت only unilateral weakness or even just slurred speech, the duration of symptoms, and history of diabetes. And based on the score, if we have someone with moderate to high risk, he needs to be admitted for further workup as an inpatient because this patient has high risk of re-stroke again. Or if the score is low, we can discharge the patient with close follow-up. And by close, I mean 2 to 3 days with neurology for outpatient Doppler, echo, Holter. If I cannot ensure a close follow-up, then it's better to admit the patient. What about ischemic stroke? Again, remember that some patients, as per guidelines, some patients are candidate for thrombolytics. Those patients are the patients who present within the first 3 to 4.5 hours of their stroke. But please keep in mind, before you activate the stroke code, before you give thrombolytics, do a point of care glucose and make sure that the patient is not hypoglycemic. Also, do your CT head to exclude the presence of hemorrhage. لأنه مو معقول يكون الآدمي عنده hemorrhage وأعطي له thrombolytics, which is basically a super blood thinner. So please do the CT head to exclude hemorrhagic stroke, and then if the patient is within the window, has no contraindication to thrombolytics, as per guidelines, you should do. Also keep in mind to control the blood pressure as needed. Finally, we have hemorrhagic stroke. So hemorrhagic stroke, when you have a patient with hemorrhagic stroke, it's key to control their blood pressure. So keep the MAB at 110 millimeter mercury, or target the blood pressure of 160 over 90 millimeter mercury. Of course, consult neurosurgery and give seizure prophylaxis. Finally, just a recap. So when you have a patient presenting with weakness, someone presenting with picture of a stroke, again, remember to approach this patient in an ABC kind of manner. So airway, breathing, circulation. So airway, breathing, circulation, and point of care glucose, focused history and physical examination, ancillary testing, so labs, ECG, neuroimaging. The management depends if it's a TIA, stroke, ischemic or hemorrhagic stroke, so it's reperfusion versus blood pressure control, and the disposition, it depends really on the entity. So something that we have to talk about just briefly is the pre-hospital kind of care that you can give to someone presenting with weakness. So again, if you're a bystander, someone who's you don't have your medical equipment with you, so just recognition is more than enough. So please, if you notice someone with with facial drop, slurred speech, or weakness, please, time is of the essence. So time is brain. Contact your emergency medical services or take the patient to the nearest hospital immediately. Now, what if you're a paramedic or someone from EMS and you encounter this patient who called you with weakness? So again, as an EMS, the first thing to do is airway, breathing, circulation, and please check blood glucose. So it's very important. You can literally resolve everything if you recognize that the patient is hypoglycemic. You can obtain your ECG as an EMS, you can put the IV lines, you can give the patient dextrose, and you can solve everything. And it's very important if you're a paramedics, one of the important things is to try to direct the patient immediately to a stroke center. So if you recognize someone with a stroke or possibility of a stroke, please coordinate with a hospital that has a stroke center, if you can, of course. So another question is, should we give aspirin? Should we not give aspirin? So the correct answer is it really doesn't matter. So aspirin has to be given in the first 12 hours. So whether you give it now, you give it later, usually what we do in the emergency department is that we leave it to the neurologist. There is no urgency. So we have a couple of diseases in which early management makes a difference. So when I have someone, for example, with myocardial infarction or suspected ACS, I immediately give aspirin because as per evidence, early aspirin makes a difference. If I have someone with sepsis, early antibiotics makes a difference. But regarding stroke, aspirin is not of the essence. I can really leave it to the expert later on. So there is no urgency to give aspirin on the scene. There is no urgency to give aspirin by EMS individuals. There is no urgency to give aspirin by emergency physicians. Of course, if I have a patient with TIA and I'm going to discharge the patient, I can discharge the patient on aspirin. But what I mean is no need to give the aspirin immediately right now. Okay. So should we take 5 minutes break before we talk about seizure? So someone is asking about the Rosier score or the ABCD2 score in emergency department regarding TIA. So Honestly, I did not review the evidence regarding Rosier score versus ABCD2 score, but usually we go with the ABCD2 score to decide whether to discharge or admit someone. Someone is asking disposition. So disposition, what I mean is admission or discharge. يعني حنخرج المريض البيت ولا I will admit the patient under the appropriate specialty. تمام? Any more questions regarding stroke? So someone is asking whether we should think about a stroke if glucose is not too low. So really it depends on how low you think glucose is. So the problem is there is no real cutoff. So usually less than 60 milligram per deciliter is considered as too low. But sometimes patients who, especially type 2 diabetics who are not controlled, their body is accustomed to very high levels of glucose. Sometimes they develop symptoms even less than 100 milligram per deciliter, which is not very low. يعني in a normal individual, I would not eat يعني 90 milligram per deciliter ولا شيء. But sometimes because their bodies are accustomed to high levels of glucose, this considered as hypoglycemia. Again, whenever you suspect hypoglycemia, give dextrose. And again, you can still think of stroke and do your CTs, do your labs, your ACG. If you are still not comfortable with discharging this patient, there is no harm contacting your neurologist and taking their opinion and consulting them as well. Someone is asking if there is a difference between ischemic and hemorrhagic stroke. So yes and no. So sometimes both of them present with the same pictures and sometimes they are different. There is really يعني so there are subtle hints. يعني sometimes with hemorrhagic stroke you can see unequal pupils if there is signs, if there is impending herniation, for example. But in an essence, both of them can present with the same pictures. Both of them can present with just left-sided weakness or right-sided weakness with facial drop and slurred speech. Both of them can present with decreased LOC with seizure. So there is nothing you can يعني ما في شيء تحلف عليه. Sometimes زي ما قلت انه احيانا يكون عندك unequal pupils ولا يكون بدا الكاشنج ريفلكس واضح قدامي, which is signs of impending herniation. I start to think more of a hemorrhage, but even ischemic stroke can cause herniation as well. So the best thing to differentiate between both ischemic and hemorrhagic stroke is urgent non-contrast CT brain. Because as we said, non-contrast CT brain for hemorrhage is 95 to 100% sensitive. No, so someone is asking, is it possible for hemorrhage not to appear in CT scan in the first 24 hours? When we talk about a hemorrhage like intracerebral hemorrhage, no way. A intracerebral hemorrhage will definitely appear on your CT scan. Now, the problem is with subarachnoid hemorrhage, and we're going to talk about it later on. When to use fibrinolytic therapy? So as per guidelines, fibrinolytic therapy, the golden hour is 3 to 4.5 hours from the onset of symptoms. And you have to be very clear regarding the onset. And again, when we ask about the onset, we ask about the last time the patient was well. يعني واحد جايني ويقول لي عندي weakness من ساعتين، أسأله أنت كنت صاحي وبدأ معاك الضعف هذا ولا صحيت من النوم ويدك ضعيفة زي كده؟ إذا قال لي لا صحيت من اليوم ويدي ضعيفة، أوكي الساعة كم نمت؟ ولما نمت كنت كويس ولا لا؟ So this is the question. Of course, we have contraindications to thrombolytics, many contraindications to thrombolytics that we have to go over it one by one. Usually, we leave the decision to give to thrombolytics to our colleagues, the neurologists. So patients with diabetes are likely to develop stroke, definitely, on hypoglycemia only or also as hyperglycemia, also as hyperglycemia. So in general, diabetic patients, they have high risk of developing stroke. حتى لو كانوا controlled، حتى لو كانوا أحسن ناس في الدنيا، they still have higher risk than other people for developing a stroke. So not only hypoglycemia, حتى لو كانوا controlled, they are at risk of developing stroke. So I think we should move on and talk about seizure. Again, if you have any questions, and feel free to ask anytime. So seizure and status epilepticus. Objectives. So background, types, evaluation, and general approach. So pre-hospital and hospital. So the pathophysiology of seizure. Basically, it's an abnormal electrical activity in the brain that causes involuntary movement or altered mental status. So as we said, the pathophysiology is caused by a pathologic pattern of brain cortex activity that leads to involuntary movement or change in the level of consciousness. So what about status epilepticus? So the definition of status epilepticus is a seizure that lasts for more than 5 minutes or 2 or more seizures without full recovery. يعني again, seizure that lasts for more than 5 minutes أو لو كان عندي 2 seizures and in between the patient did not return to his full consciousness. This is a status epilepticus. طبعا the definition is very important of status epilepticus لأنه حيجيك patient ويقول لك يا أخي أنا ولدي لي 15 مرة بتشنج في البيت. فيبدأ في الهيستوري. How a duration of each episode والله بيقول لك 1 minute. طيب between each seizure and the next does the patient return to his full consciousness؟ يقول لك ايوه بيصحى وبيفوق ويعرفنا ويتكلم معانا بس يرجع يتشنج تاني. فهذه ما صارت status epilepticus. تمام. The definition of status epilepticus: more than 5 minutes per seizure or 2 seizures or above without full recovery. So statistically 11% of people will have at least 1 seizure in their lifetime and 3% will have epilepsy. طبعا these statistics are again from the US. So what about the types of seizure? So we can divide seizure into generalized seizure and focal seizure. So let's go back to the generalized seizure. So generalized seizure, it's a seizure activity involving both hemispheres of the brain. And we can further classify generalized seizure into tonic, clonic, tonic-clonic, myoclonic, atonic, and absent. So tonic seizures, as you can see here in the picture, tonic seizures causes a stiffening, tension, or flexion of the body and extremities, which can cause the sufferer to fall backward. So basically, you have someone whose body is so stiff all over. Clonic seizures, on the other hand, they are characterized by repetitive and uncontrollable jerking of body parts, including the arms and legs. يعني the patient will continuously experience flexion and extension of the upper arms and lower arms in a very rhythmic and fast manner. So what about tonic-clonic seizures? So tonic-clonic seizures, we have 2 phases. The first phase, it's a tonic phase. وزي ما قلنا tonic phase معناها the patient's body is so rigid and stiff. And then he goes into a clonic phase in which his arms and legs start to rhythmically and repetitively flex and extend. Another type of seizure is called myoclonic seizures. So myoclonic seizures usually start between the age of 3 and 12 years old. And this type of seizure is very brief and often only lasting for a few seconds. The sufferer will not lose awareness during the myoclonic seizures, and usually they experience muscle spasm, jolts, or twitching that are localized or may affect the whole body. Atonic seizures are a little bit challenging because another term for atonic seizures are drop attacks. So these patients, they just drop. it looks like syncope, it looks like loss of consciousness. So it's really difficult to tell the difference between atonic seizure and syncope. Yes, there are multiple hints that we can use. We can't talk about them right now. So, and this is very important to differentiate between syncope and atonic seizure. So when you take the history of someone with loss of consciousness, you have three parts of your history. You have the pre-event, the event itself, and post-event. So the pre-event, you start to ask the patient, did you have aura? And by aura, we mean abnormal sensation, abnormal smelling, abnormal perception, abnormal or any kind of hallucinations. So if the patient has some kind of aura, it goes more with seizure. But someone who experienced chest pain or palpitations or diaphoresis or shortness of breath, nausea or vomiting, it goes more with syncope than seizure. When it comes to the event itself, in general, the uprolling of eyes, frothy mouth secretions, apnea, cyanosis, loss of bowel or bladder control, it goes a little bit more with seizure. But again, syncope can present with abnormal movement and seizure can be atonic. So keep this in mind. One of the most important questions that you have to ask about anyone who experience loss of consciousness and you are not sure whether this is syncope or seizure is tongue biting. So lateral tongue bite is 100% specific for seizure. يعني لو عندي patient حتى لو كانت atonic seizure وعنده lateral tongue bite, it's almost 100% specific for seizure. Then we have the post event. So post event يعني بعد ما انتهت الابنورمال موفمنت او بعد ما صح البيشنت، هل في post ictal phase ولا لا؟ And by post ictal I mean drowsiness, sleepiness, confusion, or even agitation. If there is a post-ictal phase, it goes more with seizure. Like in someone who immediately woke up and his conscious, alert, oriented, completely normal, it goes more with syncope. So keep this in mind. Finally, we have absent seizures. So absent seizures are formally called petit mal seizures. Activity occurs throughout the entire brain. Again, it's a generalized type of seizure and causes unconsciousness but no convulsions. Usually بتحصل في pediatric patients in which the patient doze off يعني يكون جالس أموره كويسة, suddenly he's not aware. He's blinking but he's not aware. كأنه بيطنش. So if you have someone, especially pediatric patients, if you have a pediatric who is behaving like this, maybe it's an absent seizure. So this patient should see a specialist. So the other types of seizures are focal seizures, and we can basically, of course, it involves only one part of the brain, as you can see in the diagram up above. Focal seizures involve one part of the brain. That's why it's called focal seizures. And they are classified into simple and complex. So simple seizures, there is no loss of consciousness. So the patient will experience abnormal movement in one limb usually, يعني a right arm, left leg only, without losing his consciousness. Complex seizures or complex focal seizures, there is loss of consciousness. So why did I waste a lot of time talking about the types of seizure? Because describing the seizure morphology or semiology is very important, because by the time the neurologists come, the seizure should have been aborted. You give your medications, so you're the only one who can effectively describe the seizure to the neurologist. And depending on the semiology, the neurologist will think about different pathology. So it's very important to know the types of seizures and how to describe them. So the differential diagnosis of seizures can be classified into epileptic seizure or non-epileptic seizure. So when we talk about non-epileptic seizure, we're talking about syncope. We're talking about vestibulo-basilar artery insufficiency or movement disorder or even migraine. Drugs and toxins like delirium tremens, psychiatric illness. When we talk about epileptic seizures, It could be drugs, so alcohol intoxication, stimulants like amphetamine, medications like antiarrhythmic, antidepressant, antipsychotics. It could be a metabolic cause. So again, hypoglycemia can cause seizures. So please 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 احنا تعلمنا في الكلية انه الفيتال ساينز 5: heart rate, respiratory rate, blood pressure, oxygen saturation and temperature. بس الامرجنسي علمنا انه الفيتال ساينز 6. So the sixth vital sign is RBS. So please always do your RBS. So hypoglycemia or hyperglycemia, hyponatremia and hypernatremia, hypocalcemia and hypomagnesemia. All of them can present with seizures. Infectious causes, so meningitis, encephalitis, abscess. Structural causes, so intracerebral hemorrhage, subarachnoid hemorrhage, tumors and strokes. And finally, systemic, so eclampsia and thyrotoxicosis. So the differential diagnosis of stroke is very wide, but the critical differential diagnosis that I want you to remember at all times are these. So the critical differential diagnosis of seizures and the causes of reversible status epilepticus are the following. So eclampsia, toxic ingestion, hypoglycemia, hyponatremia, and increased ICP. So whenever you have a female patient who's obviously gravid and now she's seizing, and this is the first time she's seizing, please think of eclampsia and give her magnesium sulfate. Also keep in mind that eclampsia can present 8 weeks after delivery. So if you have a female patient who's seizing in status epilepticus, refractory to medication, please ask the relative, ask the caregiver, ask anyone who knows the patient if she recently delivered, because again, eclampsia can present up to 8 weeks after delivery, and the management is magnesium sulfate. Toxic ingestion, so INH toxicity. So we give INH for patients with tuberculosis. So again, it's very important to ask if the patient is on any antibiotics, if the patient has lung infection or recently has been diagnosed with TB. The management of INH toxicity is to give pyridoxine, tricyclic antidepressant. So ask if the patient has depression, ask the relative if someone in the house has depression, if they found bottles around the patient when she started to seize, because TCA toxicity can cause this. And the management in TCA toxicity is sodium bicarb. Hypoglycemia. So again, always ask about RBS. If the patient is hypoglycemic, give him dextrose. Hyponatremia. If the patient is hyponatremic, hypertonic saline. And increased ICP, well, it's really difficult to tell in someone who's seizing, but history can help. The thing you can do in someone who's seizing because a suspected high intracranial pressure is to intubate the patient, elevate the bed, give mannitol, hypertonic saline, do your CT, and consult your neurosurgery. So please, please do not forget, if you're going to remember anything from seizure, remember these 5 causes, because they are very important, and they the majority, some of them, they are actually reversible. So again, eclampsia, toxic ingestions, including INH and tricyclic antidepressants, hypoglycemia, hyponatremia, and increased ICP. So let's talk about the approach to active seizure. So first of all, we're going to talk about a bystander. So what if you are a bystander? So you're walking in a mall and suddenly someone is seizing beside you. So what should you do? So this is a nice infographic about the things that you should do and things that you should not do. So first, let's start with the things that you should not do. Please don't hold down their tongue. So there is a myth that people can swallow their tongue. So please, this is a myth. Don't put your hand inside the mouth. Don't hold down their tongue. Actually, don't put anything in their mouth. So the problem is, in a normal individual, we have something called the epiglottis. When we swallow something, the epiglottis will close the airway so that whatever I swallow will go directly into my GI tract. The problem is, this patient who is seizing right now, He has no coordination whatsoever. So there is a high possibility the epiglottis is not functioning properly. So there is a high chance that if I give the patient who is seizing right now something through their mouth, it will go to their lungs. So if I give the patient even their pills, يعني حتى لو البatient known case of seizure disorder and he's seizing right now, don't give the patient their pills or their formulas because you want to stop the seizure. No, because the problem is there is a high chance whatever you're going to give through their mouth, through the oral cavity will go to the lungs and cause pneumonitis and aspiration pneumonia. So يعني you will turn the event from a simple seizure that can be dealt with in ER and hopefully be discharged home into aspiration pneumonia that needs to be admitted or sometimes even intubated and ICU observed. So please don't hold the tongue. Please don't put anything in their mouth. Now and again, don't restrain them. So if the patient is seizing, don't restrain the patient. A lot of times, especially bystanders, يعني, when we talk about the relatives, the family of the patient, when he starts to seize for the first time, they panic and they start to hold the patient. So this is very important to avoid, because if you restrain the patient, you might actually cause trauma. So with a repetitive movement, you can fracture their bones and sometimes even dislocate their shoulders. So the thing is, leave the patient to seize on their own pace. And we're going to talk about the things that you should do, but restraining them is definitely one of the things that you should not do. Again, you do not want to transform a simple seizure into a fracture that need casting or even surgery. You don't want to transform a simple seizure into a shoulder dislocation that needs sedation and reduction. And the most important thing is, please don't panic. So the golden rule in ER is that if the team leader panicked, everyone else will panic. So please don't panic. If you started to panic, just take a step back, take a deep breath, and relax, because everything is going to be fine. So what should you do in someone who's seizing? So first of all, remain calm. This is the golden rule. The second thing, support their head and open their airway if you can. And by opening their airway, we're talking about simple maneuvers. And I hope that my colleagues before me taught you how to open the airway. It's really simple. Just head tilt, chin lift. If it's not enough, a little bit of jaw thrust, but please don't put anything in the patient's mouth. And just a simple maneuver. Support the head, open the airway, and stay with the patient. Also, turn the patient on their side. So either put the patient on the left side or the right side. Why are we doing this? Again, the patient cannot really handle the airway really well. He's seizing, the epiglottis is not functioning correctly. So I do not want the patient to vomit and then aspirate. I don't want the patient to vomit and then all the vomitus will go to the lungs. So the best way to avoid this is to put the patient on the right side or the left side, so that if the patient vomit, he will vomit outside. He will not swallow anything. Okay. And of course, create a safe area. So if there are clear, sharp objects, if there are sharp objects, remove them. If there are dangerous items, avoid them. If the area is not safe for you or for the patient, then transport the patient to a safer area. And please get rid of the onlookers. And please get rid of the onlookers during the seizure attack. طبعا الonlookers هم الملاقيف اللي ما بيسووا شيء. من يوم ما يشوفوا في سيجر او يشوفوا في اي مصيبه لازم يتجمعوا. يعني مو كفايه الادمي بتشنج والدنيا كتمه، كمان يتجمعوا ويكتموك وتقول له طيب يا اخي ايش بتسوي؟ يقول لك بساعد، هو قاعد يصور. So please get rid of those people because they are the source of panic. Please get rid of them. If anyone is not helping, please step back. طبعا again, help the patient to sit or lay down and stay with them. And of course, in case of an emergency, please call 911. Please involve your emergency medical services. And if at any point the patient collapsed, there is no pulse, perform CPR immediately. So now we will talk about a step-by-step approach to active seizure in the emergency department. The first thing you're gonna do is, of course, ABC. So airway, breathing, circulation. And please, I want the first question to come out from your mouth whenever you have someone seizing is, what's the patient's blood sugar? Tamam? As we said, hypoglycemia, it's usually overlooked and it's easily reversible. Yani, seriously, you don't want someone who's seizing and you give your benzo, you give your second line, you started to intubate and he's just hypoglycemic. يعني الآدمي ما عنده سكر، تعطيه سكر يرجع normal. As simple as that. So please, the first question to come out from your mouth whenever you have someone who's seizing is, what's the patient's blood sugar? So of course, start with the point of care glucose. If it's normal, put the patient on the lateral side, open the airway with simple maneuver, attach the monitor and provide oxygen, and have the nasal airway and suction with you if needed. So someone was asking if we can suction someone who's seizing. Yes, definitely. You can suction someone who's seizing, but please be careful. Don't go too deep if you don't have to, because you don't want the gag reflex to be stimulated, and you definitely don't want them to vomit. So have the nasal airway and suction with you if needed. The second step is to get an IV access. And remember, if you cannot obtain an IV access rapidly, then please place an intraosseous line. So after you establish your IV access, send for your VBG and your basic workup. Now, a VBG is very important because one of the things that we talked about is hyponatremia, and you're gonna see that in your VBG. So if you have a severe hyponatremia causing seizure, you have to give hypertonic saline 3%, 150 ml over 20 minutes. So let's assume that the patient has a normal blood sugar. VBG is normal. So the first line you're gonna give is benzodiazepine. So we have three types of benzo. We have lorazepam, midazolam, and diazepam. So lorazepam is preferred. If you have lorazepam, then go for it. But if you have midazolam or diazepam, then please use any one of them. By evidence, all of them are equally effective. So lorazepam, the dose is 0.1 milligram per kg IV, maximum 2 to 4 milligram. Midazolam is very interesting. The dose is 0.2 milligram per kg, but you can give it IV, you can give it IM, and you can give it even intranasal. So if you're having trouble with your IV access, you can give midazolam IM. Then we have diazepam. It can be given IV or even rectal, so 0.2 to 0.5 milligram per kg IV, or 0.5 to 0.1 milligram per kg PR, maximum 10 to 20 milligram PR. So usually we give benzo, we observe the patient for 5 to 10 minutes, we give a second dose of benzo, we observe 5 to 10 minutes. And remember, you're not only observing at this time, you're actively looking for the reversible causes. So you're looking for the glucose, you're looking for the VBG for hyponatremia, you're looking at the patient and doing physical examination for any signs of trauma that may indicate high ICP. You're looking at the patient if she's female for a gravid abdomen that may indicate eclampsia. You're asking the relative for the chance of drug toxicity or any recent deliveries. By the third dose of benzo, if you reach the third dose of benzo, the next thing to do is to jump to the second line. So again, we give 3 doses of benzo. Between each dose and the next one, we wait 5 to 10 minutes. If we reach the third dose of benzo, we give it and we look for the second line. So second line, we have levetiracetam, also known as Keppra. The dose is 60 milligram per kg. Phenytoin, fosphenytoin, valproic acid, phenobarb. The doses are 20 milligram per kg. So usually in adult patients, we give levetiracetam or phenytoin. In pediatric patients, we give phenobarb or valproic acid. And regarding adult patient, there is no superiority whether you go with levetiracetam or phenytoin. Just use whatever you have and whatever you're familiar with. So let's assume that you gave 3 doses of benzo, you give levetiracetam or phenytoin or whatever second line you chose, and the patient is still seizing in front of you. So this is a refractory seizure. At this point, again, please review your patient and make sure you're not missing something like INH toxicity or tricyclic antidepressant toxicity. Make sure you're not missing a gravid abdomen or the chance of eclampsia in someone who recently delivered. Make sure that you took your glucose level. Make sure you looked at your VBG and your basic labs. If you still do not have a reversible cause, then at this point you have to intubate the patient. And the reason why we intubate the patient is because we want to protect the airway. We want to make sure that the brain is adequately oxygenated, and we want to stop the muscle contractions, because if the patient's muscle contracted for a long time, he will go into something called rhabdomyolysis, which will cause renal failure. So at this point, I'm just trying to stop the activity of seizure. So the seizure itself is not over. So even though the patient is not externally seizing after intubation, لكن لو حطيت EEG electrodes on his or her head, I will see epileptic waveforms. So just remember انه at this point لما نوصل اني اعطي كل الفيرست لاين واعطي السكند لاين and the patient is still seizing, I'm intubating because I want to prevent the complications of seizure. I want to protect the airway. I want to provide good oxygenation for the brain, and I want to prevent rhabdomyolysis. Those patients, they require extensive investigations, including CT brain, to look for any bleeding or any mass lesion that is causing this form of refractory status epilepticus. So let's assume that you had this patient who was seizing. You gave him the medications. You started benzo, and the patient is now not seizing. Now is the time to evaluate the patient extensively. So the first question that you should ask is this a first-time seizure, or is the patient a known case of seizure disorder? So let's go with yes. So this is the first time the patient has ever experienced seizure. So معلش. So assess for potential triggers. So in the history, ask about medications. Make sure the patient is not immunosuppressed or immunocompromised. Physical examinations, look for signs of head trauma. Look for focal findings on neurologic examination, signs of intoxication, and ancillary testing. So look for a full metabolic panel, so serum glucose, electrolyte level, and liver function test, as well as drug level. If you're suspecting alcohol intoxication, then blood alcohol level and urine tox screen. So after your assessment, if you have focal neurologic examination or the patient is immunosuppressed, then perform a CT scan. If there is no focal neurological examination, after the seizure, the patient is now fully conscious, alert oriented, the patient is not immunocompromised, then you can perform CT if needed, or you can arrange for an outpatient CT. As long as the patient has no focal neurological deficit, as long as the patient is conscious, alert oriented, and has no history of immunosuppression or immunocompromised, you can discharge the patient safely. Now, if the patient is a known case of seizure disorder, then we have to ask specifically about the character of the seizure. So the onset, the aura, duration of the seizure, is it partial or generalized, as well as the post-ictal state. So if the seizure today has the same semiology, the same features as the usual seizures, this is reassuring. It means it's the same pathology. Like if the seizure today is different, سواء في الكاركتر، يعني هو usually partial واليوم جاني generalized، usually عنده specific aura واليوم الاورا حقته مختلفة، الديوريشن اليوم more than usual، او البوست اكتال state حق البيشنت is different. Usually the post ictal state of the patient is that he's confused, drowsy, but today the post ictal is agitation. It means that there is something different. It means that the seizure today has a different pathology, and in this case I have to assist the patient, as we said, just like I'm dealing with a first time seizure. But if the seizure today has the exact same semiology as the previous seizures for this patient, then the first thing we do is to check the anti-epileptic drug level and assess for factors that lower the seizure threshold, like infections, for example, or the use of new medications. And we ask ourselves, does the patient need to be loaded? For example, I did my, sorry. So, for example, I did my phenytoin level and it's subtherapeutic. So if I need to give the patient some sort of loading, I can give it, as simple as that. يعني جايني اليوم patient known case of seizure disorder، جاي بنفس السيجر حقت كل مرة، ولما بسأله بيقول لي يا أخي لي شهرين ما باخذ الفينيتوين حقي. So it's very simple. I just need to load the anti-epileptic drug to re-establish the therapeutic level and then discharge the patient home. And that's it regarding seizure. So let's relax for 1 or 2 minutes and then we will go to altered mental status. Okay, let's continue. So altered mental status. So background, delirium versus dementia, differential diagnosis, and general approach. So altered mental status. So altered mental status. Altered mental status is defined as an acute alteration in brain function. So in Arabic, we ask the patient, or we ask, sorry, the relative, هل المريض وعيه اختلف عليكم ولا لا؟ إذا قال إيوه معناها this is altered mental status. السؤال الثاني من متى؟ والله قال لي من أسبوع معناها this is acute. قال لي والله اختلف علي من 4 شهور معناها this is chronic. So basically any alteration in the brain function, and we have really to make sure what exactly is their perception. يعني أنا بسأل وبقول له هل وعي المريض اتغير عليكم؟ وبيقول لي إيوه. السؤال الثاني كيف اتغير عليكم؟ هل صار نايم طول اليوم؟ هل صار مضيع مو عارف هو فين ومين حواليه؟ هل صار يتلفظ بألفاظ ويسبسب ويقول كلام هو ما كان يقوله من أول؟ So we have to identify the type of altered mental status. Now keep in mind that both cerebral cortex or brainstem must be affected for an altered mental status to develop. So it's very important to differentiate between delirium and dementia. So the delirium, it's an acute altered mental status, something that I need to identify and to deal with in emergency department, while dementia, it's a chronic altered mental status. So it's something that should be done in an outpatient kind of setting, and sometimes even in the primary healthcare. So delirium, the onset is acute, while dementia, it's a gradual onset, something over months to even years. The course of delirium is fluctuating. So the relative will tell you that for the last couple of days, he comes and goes. يعني المريض يروح ويجي، فجأة يضيع وفجأة يصير كويس، فجأة يضيع وفجأة يصير كويس. So this is very characteristic for delirium. The consciousness is usually altered in delirium, while in dementia, the consciousness is usually normal. بمعنى انه في الديليريوم البيشنت is usually somnolent يعني sleepy drowsy، لكن في الدمنشيا لا، البيشنت is totally conscious لكنه مضيع. So orientation, so again في delirium it's fluctuating and we can sometimes observe this during the emergency course. يعني أول ما يجي المريض بيكون disoriented، أروح أرجع بعد ساعة ألقى رجع normal، أروح أرجع بعد ساعة ألقى صار disoriented. So this is again very specific for delirium. While for dementia it's impaired. The patient is almost always disoriented. The duration of delirium, again, it's an acute onset, so hours to couple of months. While dementia, it's months to year. بنتكلم أحيانا 4 or 5 months. Hallucinations are common in delirium, لكن في dementia they are rare until very late stages of dementia. Regarding the attention, بيكون impaired في delirium ويكون normal في dementia until very late stages. So it's very important to differentiate between delirium and between dementia. So the differential diagnosis of altered mental status is very extensive. Almost anything can cause altered mental status. We can divide it into CNS and systemic causes. So CNS causes, we have structural causes like subdural hematoma, subarachnoid hemorrhage, and epidural hematoma, a mass lesion, سواء malignancy or abscess, vascular injury, سواء stroke or venous sinus thrombosis, infectious cause, so meningitis, encephalitis, seizure disorder like status epilepticus, or something systemic. Or something systemic, so shock in general. I'm sure that the guys already told you about the types of shock. So any shock can cause altered mental status. So cardiogenic shock, obstructive shock, hypovolemic shock, or anaphylactic shock. Anything that can decreases the blood flow to the brain can cause altered mental status. So hypoxia, سواء PE, asthma, or COPD can cause altered mental status. Toxic or metabolic conditions. So again, hypoglycemia, you can see it as the first thing, hypoglycemia. So again, please, 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 whenever you have someone with any neurologic manifestations, سواء كانت altered mental status, picture of a stroke, seizure, please, the first thing that you should ask is what's the patient's blood sugar. Hyperglycemia like DKA or HHS اللي هي hyperosmolar state can cause altered mental status. Electrolyte disturbance سواء sodium or calcium. Hepatic encephalopathy, uremic encephalopathy, Wernicke encephalopathy can cause altered mental status. And finally we have endocrine causes. So thyroid diseases سواء كانت thyrotoxicosis or myxedema coma, or adrenal insufficiency. Again, the differential diagnosis is very wide and honestly, it's easily forgettable. So one way to remember it is to have a mnemonic. So there are many mnemonics regarding altered mental status. There is the I watch death. Another mnemonic is IEIOU DIPS. But honestly, this is the simplest mnemonic I found. It's DIMES. So D for drugs, سواء intoxication or withdrawal. I for infections, meningitis, encephalitis, brain abscess, and sepsis. M for metabolic conditions. We're talking about thyrotoxicosis, myxedema, coma, adrenal insufficiency, environmental and electrolyte, and finally, structural and and shock. So if you have this mnemonic, hopefully you will not forget any of the causes of altered mental status. So what about the approach? So again, as we said, altered mental status, it could be anything. It could be confusion or it could be decreased level of consciousness. So let's talk about confusion. So you have someone who's confused, who's disoriented, and this is something acute. And it is changed from his baseline. So the first thing, please check the glucose and check the patient's oxygen. If any of them is abnormal, then correct as needed. By the way, can you see my mouse pointing? Or do I need to use the laser pen? Okay, let's use the laser pointer. Hopefully it's okay. So yeah, so first of all, check the glucose and oxygen check. If any of them is abnormal, then please correct as needed. If both glucose and oxygen are normal, then check for any toxidrome. So I'm not sure if you took toxicology course yet, or if anyone told you um, about toxins, but many of the toxins, they have a specific toxidrome. By toxidrome, I mean a collection of symptoms. If you have these collections of symptoms, it means that the patient is intoxicated by a certain drug. If you have a toxidrome, then give the antidote as appropriate. If there is no specific toxidrome, then look for a focal findings or on neurologic examination. If you have a focal finding, so you have lateralization, or you have facial drop, or the patient has slurred speech, then we're talking about a stroke, we're talking about a tumor, we're talking about some sort of hemorrhage, in which case you definitely need to CT the patient and involve the appropriate service, whether it's neurology or neurosurgery. If you don't have a focal finding, then maybe it's an infectious process. Maybe this is sepsis. Maybe it's meningitis or encephalitis. So check if the patient is febrile or has a history of fever, and check if the patient meets SIRS criteria. If yes, then this is possibly a sepsis. ممكن تكون pneumonia, UTI, skin infection, CNS infection. Anyways, these patients need early antibiotic with partial septic workup, with or without lumbar puncture, depending on your suspicion. If there is no fever, no history of fever, no SIRS, and you still don't know the diagnosis, then this patient needs extensive workup. So you basically send everything, CBC, electrolyte, you do your partial septic workup, chest x-ray, ECG, urine analysis, you go with your CT, ABG if needed, CSF and lumbar puncture if required, thyroid panel, toxicology studies. If you still don't know, then please don't discharge such patient home. Patients with acute confusion should be admitted and worked up as an inpatient. So consult and admit the patient. So what if the patient has altered mental status in the form altered mental status in the form of decreased level of consciousness? If the patient has decreased level of consciousness, then we follow this simple diagram. So patient presented with decreased level of consciousness, then sure, it's ABC, airway, breathing, circulation. So measure the glucose, obtain IV access, maintain saturation at 9 to 7%, initiate cardiac monitor, obtain ACG, portable chest X-ray, and point of care labs. If the patient is hypoglycemic, give dextrose. If opioid toxicity is suspected, give naloxone. If the patient is malnourished, then you might give thiamine. And then do a complete physical and neurologic examination. If after giving dextrose or naloxone or thiamine, the patient actually improved, then treat and observe. But if the patient did not improve, then depending on the level of consciousness, if it's too low or deteriorating rapidly, you might need to secure the airway and to administer antibiotics if infection is suspected, and to go with your advanced imaging. So CT with or without CTA, and consult the appropriate specialty. Okay, now we're going to talk about headache. Let's just take 1 minute break. Okay, someone is asking if this is Italy or not. والله صراحة ما أدري، يعني أنا دخلت جوجل وكتبت wall paper HD وحطيت لكم الصورة هذه يعني. فالمكان لطيف والله بس ما أعرف فين. Okay, let's continue. So headache. Yes, let's continue. So objectives: primary versus secondary causes, red flags of headache. We're going to focus on meningitis, encephalitis, and subarachnoid hemorrhage because these two topics are a little bit challenging, especially subarachnoid hemorrhage. So let's start. So what do I mean by primary headache and secondary headache? So basically a secondary headache is a headache that is caused by something abnormal in our body. So whenever you have, for example, meningitis, it's a cause of secondary headache. Bleeding, it's a cause of secondary headache. Vascular disorder like giant cell arteritis is a cause of secondary headache, as well as a space occupying lesion. But when I have someone who's complaining of headache and everything is normal, we call this primary headache. And we have migraine, tension headache, cluster headache, idiopathic headache, and exertional. So especially the first four, migraine, tension, cluster, and idiopathic, are not really that dangerous. It's important to know them and to know how to deal with them, but they are not critical differential diagnosis. What I really care about are the secondary headache. These are the headaches that I need to discover and I need to treat appropriately. So what are the red flags of headaches? So when I say red flags, I mean things that if the patient has, I should be very careful and should take this patient extremely, extremely seriously. So the mnemonic is SNOOP. S for systemic signs and symptoms. So someone, for example, who's complaining of apologies. So systemic symptoms, it means someone who's complaining of fever, for example. Neurologic symptoms, so someone who's complaining of weakness. When you examine the patient, he has lateralization, he has focal weakness. Those patients need to be taken extremely, extremely seriously. Onset, so a headache that is new, or someone who's a known case of migraine, but right now he's telling you this headache is totally different, or someone who is more than 50 years old, those patients need to be taken seriously as well. Onset, that is thunderclap in presentation. So thunderclap is one of the very important and iconic terms in emergency medicine because a thunderclap headache is almost equivalent to subarachnoid hemorrhage. So please don't forget thunderclap headache. And we're going to talk about thunderclap and subarachnoid later on. Finally, P for papillary edema, which is a sign of high ICP, and we can look for papillary edema with ultrasound in emergency. Pulsatile tinnitus, positional provocation, and precipitated by exercise. So these are the red flags of headache. So let's start by talking about meningitis and encephalitis. Excuse me. So let's talk about meningitis and encephalitis. So microbiology, the majority of meningitis and encephalitis are caused by bacterial or viral pathogens. So the most common in adults, it's pneumococcal, and in viral, we're talking about echovirus, Coxsackie virus, enteroviruses. The pathophysiology, well, the pathogen reaches the meninges either through hematogenous spread via the respiratory tract or direct spread. So someone who has otitis media, sinusitis, or brain abscess, this infection can extend and reach the meninges. So the clinical features, almost all adults will present with at least two of the following: headache, fever, neck stiffness, altered mental status, with or without skin rash. Other non-specific symptoms include photophobia, vomiting, a prodrome of upper respiratory tract infection, focal neurodeficit, especially if the cranial nerves are involved, and sometimes seizure as well. So regarding the clinical features, we're talking about the physical examination. So of course, we're going to do a full head to toe examination, but these specific findings are very important. So the first one is knuckle rigidity. Knuckle rigidity, it means rigidity of neck muscles with flexion. Now, even though it's not sensitive, it is fairly specific. It's 80% specific. By the way, when I say not sensitive, it means لو ما حصلت النكل rigidity ما أقول هذه ما هي meningitis. بس لو حصلت النكل من النكل rigidity, it's 80% meningitis. We have also Kernick sign. So Kernick sign, which is with flexed hip at 90 degrees, extension of knee produces pain. Now, again, it's not sensitive. It's only 2% sensitive. يعني لو ما حصلت الكيرنيك sign, I cannot rule out meningitis, but it's 97% specific. Prudniski sign, which is involuntary lifting of legs with passive flexion of neck, again, it's 2% sensitive, but it's 98% specific. There is something called the jolt test. It is very sensitive. When I say it's very sensitive, it means لو كان negative, I can almost say this is not meningitis. So the jolt test, basically, it's a horizontal rotation of the head at frequency of 2 rotations per second. If this movement exacerbated the patient's headache, it's positive. Lakin if this movement did not affect the patient headache, it's negative and it can virtually rule out meningitis. So just keep in mind that knuckle rigidity, Kernick sign, Prudniski sign, all of them are signs of meningeal irritation. Meningeal irritation بيحصل مع المننجايتس، بيحصل مع مع subarachnoid hemorrhage. So anything that irritates your meninges, it will cause these signs. Now, again, these signs, they are not sensitive, but they are extremely, extremely specific. So you have to perform them. And these two pictures illustrate the Kernick and Prudniski signs. So Kernick sign, knee is flexed at 90 degrees, hip is flexed to 90 degrees, and then I extend the knee. If there is meningeal irritation, it will be painful. Prudniski sign, basically I just passively flex the neck. If the patient elicit hip and knee flexion, it means meningeal irritation. So what's the workup for meningitis / encephalitis? So the workup, basically, I'm doing my CBC, my chemistry, my blood culture. Now the question is, can I do lumbar puncture before CT, or do I have to CT the brain and then do lumbar puncture? So it really depends. So we can actually do lumbar puncture without CT if there is one of the following. So someone who's young, less than 60 years old, the patient is not immunocompromised, the patient doesn't have history of CNS disorder, no seizure within the past 1 week of presentation. On the physical examination, the patient is completely conscious, alert oriented, and there is no neurologic finding. Then I can do lumbar puncture before doing my CT. But if the patient is elderly, more than 60-year-old, immunocompromised, has a history of CNS disease, had a seizure before coming to the ER, he has altered mental status, or has a focal neurologic deficit, I have to CT the brain because I have to rule out the presence of a space-occupying lesion, something that is causing midline shift. Because if there is midline shift and a space-occupying lesion, when I عملت ال LP, there is a chance that I might herniate the brain. فعشان كده نرجع نقول someone who's young, not immunocompromised, no history of CNS disease, and no seizure, and he's completely conscious, alert, oriented, with no focal neurologic deficit, معناها I can safely do my lumbar puncture before CTing the patient. Now, we also need chest X-ray because 50% of patients with pneumococcal meningitis have evidence of pneumonia on chest X-ray, and definitely we need to do lumbar puncture. So this is a table for lumbar puncture analysis. Honestly, there is no time to go over it one by one, but I will give you the slides later on, and you can have a deeper look at this table. But definitely lumbar puncture is very important to differentiate between bacterial meningitis, aseptic or viral meningitis, fungal meningitis, tuberculosis, as well as subarachnoid hemorrhage, because in subarachnoid hemorrhage, I will see something called xanthochromia, or sometimes even clear blood coming out through the CSF. So what about the management of meningitis and encephalitis? Now, the most important thing that you have to remember is giving antibiotics. Antibiotics should be given as soon as possible. So, and keep in mind, sometimes people they say لا تعطي الانتيبيوتيك لين ما تعمل ال LP عشان النتيجة حقت ال LP تكون صحيحة. No, this is not very accurate, because if LP is performed within 2 hours of antibiotics, CSF culture will not be affected. الانتيبيوتكس ما هو سحر، مو اني حاعطيه من هنا وسبحان الله فجأة يطلع لي في السي اس اف ويقتل كل البكتيريا. لا. It will take 2 hours for the antibiotics to cross the blood-brain barrier and reach the CSF. So I can give the antibiotics as long as I'm going to do lumbar puncture within 2 hours of the antibiotics. So please do not delay your antibiotics. The choice of antibiotics depends on the age and immune status of the patient. Usually, in general, we give ceftriaxone 2 grams IV with vancomycin 15 to 20 milligram per kg IV, with or without ampicillin 2 gram IV. But again, the choice of antibiotic depends on the age and the immune status of the patient. Now, what about prophylaxis regimen for people who are in contact with this patient? So we can give any of them. We can give rifampin for 2 days. We can give 1 dose of ceftriaxone, or we can give ciprofloxacin 500 milligram PO once only. So for prophylaxis regimen, you can give any of these antibiotics. So let's talk about subarachnoid hemorrhage. So subarachnoid hemorrhage is defined as hemorrhage into the subarachnoid space. وزي ما قلنا بداية الليكشر, a subarachnoid space, it's the space between the arachnoid membrane and the pia mater. So the etiology, قلنا 85% is ruptured aneurysm. And this is the thing that we're looking for. So a ruptured aneurysm is very important to recognize and very important to diagnose and very important to admit and involve the appropriate service. So 80% or 85% of subarachnoid hemorrhage is due to ruptured perianeurysm. Now, we have also 15% of the causes in which it's a non-aneurysmal cause. So 10%, it's something called perimesencephalic hemorrhage. Now, this is very benign. It doesn't need anything. It just needs admission for observation. Other causes including tumor, coagulopathy, dissection, vasculitis, sickle cell disease, as well as venous sinus thrombosis. And this is a picture comparing a normal CT scan and another one with subarachnoid hemorrhage. As you can see, this is a normal CT brain. And here, this is the white. As we said, blood on the CT is hyperdense. بيطلع لونه أبيض. For this whitish area is subarachnoid hemorrhage. So now I have someone in my ER complaining of headache, and I'm not sure this is subarachnoid hemorrhage or not. So what can I do? So we have something called the Ottawa subarachnoid hemorrhage rule, and we can use this to rule out subarachnoid hemorrhage, but we have to ask a couple of questions. So patients require investigation if one or more findings are present. يعني جايني واحد screaming of chest, جايني واحد complaining of headache. If the patient has symptoms of neck pain or stiffness, if the patient's age is 40 years old or above, if the patient had a witnessed loss of consciousness, if the headache started during exertion, if the patient is describing thunderclap headache, or if the patient has limited neck flexion on examination. If the patient has any of these, معناها معلش معناها I cannot rule out subarachnoid hemorrhage. لكن إذا جاني patient less than 40 years old, he's not complaining of neck pain or stiffness, no witness loss of consciousness, the onset is not related to exertion, the patient is not describing a thunderclap headache, and he does not have a limited neck flexion on physical examination, I can definitely say this is not subarachnoid hemorrhage. But if any of these are present, معناها I need further investigation to evaluate this patient's headache. Something very important is how to ask about thunderclap headache. How to ask about thunderclap headache. So thunderclap, it means that maximum intensity of headache within seconds. See الفكرة كيف حسألها بالعربي. So honestly for me the best way I found to ask this in Arabic إني أسأل المريض وأقول له هل الصداع بدأ معك خفيف وقاعد يزيد شوية 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 ولا حسيت الصداع زي الخبط على راسك. So if the patient told me yes زي الخبط على راسي, it goes more with thunderclap headache. لكن لو قال لي لا والله الصداع بادئ معايا خفيف وكل ماله يزيد شوية شوية شوية, this is reassuring. So what should I do? How do I evaluate someone with a possibility of subarachnoid hemorrhage? So first of all, we have to look at the time frame and we have to ask, when did the headache start? If the onset of the headache is less than 6 hours, the non-contrast CT scan, it's almost 100% sensitive. يعني during the first 6 hours of this suspicious headache, if I did my non-contrast CT and the CT is negative, I can reassure the patient, discharge her home with pain medication and clear red flags when to come back to ER. But if the symptoms are more than 6 hours, unfortunately more than 6 hours, the sensitivity of non-contrast CT starts to decline. If the symptoms are more than 6 hours, I do my non-contrast CT. If it's positive, ممتاز. If it's negative, I cannot rule out subarachnoid hemorrhage. فديك الساعة أعمل lumbar puncture and I'm looking basically for something called xanthochromia, which is degraded blood products. طيب, what if you have contraindications to do lumbar puncture or the patient did not agree to lumbar puncture? Alternatively, you can do CT plus CTA. طبعا whether non-contrast CT plus LP is better than CT versus plus CTA, it's an area of debate. But what we can agree upon, the safest thing to do is to do non-contrast CT plus LP. But if the patient doesn't want the LP or there are contraindications, then you can go with CT plus CT angio. And definitely, if you have subarachnoid hemorrhage, then please involve the appropriate service and admit the patient. Now, I'm going to talk just one slide about giant cell arteritis. So giant cell arteritis, it's the most common systemic vasculitis in the US, associated with polymyalgia rheumatica. One of the risk factors, and probably the highest risk factor for giant cell arteritis or temporal arteritis, is age. So it's almost never occurs before the age of 50. طبعا the clinical features, we have headache, obviously, بالإضافة للconstitutional symptoms jaw claudication, transient vision loss, also known as amaurosis vogax, and sometimes even permanent vision loss. Now, during your physical examination, it's very important to palpate the temporal area, which is the area I'm pointing at with my pointer. So if you have tenderness, if you have someone who's more than 50 years old with tenderness or absent pulses over the temporal area, you have to suspect giant cell arteritis. You're going to order your labs. If you have elevated ESR and CRP, then this is giant cell arteritis. طبعا the only way to definitely say this is giant cell arteritis is to do biopsy which is usually done as an outpatient with rheumatology. So when you suspect giant cell arteritis, please start your management. If there is no vision loss, you give prednisolone. If there is vision loss, then methylpred IV. So just keep this in mind when you are dealing with headache as well. So this is a general approach for headache. So the first thing that you have to ask is whether this is the first time or there is history of headache. So if there is history of headache before, so you have to ask the patient, is this is the same headache as always or different? If this is the same headache as always, this is probably primary headache. So again, we're talking about tension, migraine, cluster, trigger point, or analgesic cues. But if this headache is different than always, then we go with the other arm of the diagram. So the first question we have to ask ourselves is, are we suspecting some sort of infection? ولا لا? If I'm suspecting an infection, then it's either meningitis or some form of mass lesion, زي brain abscess, for example. But if I'm not suspecting an infection, then I have to think, are we having subarachnoid hemorrhage ولا لا? So I apply my Ottawa subarachnoid hemorrhage rule. If it's negative, then it's something else. It could be CVT, glaucoma, giant cell arteritis, CO poisoning, trigeminal neuralgia. بس لو إنه I cannot rule out a subarachnoid hemorrhage using an Ottawa rule, then I do my CT with or without LP as needed. Okay, now we're left with vertigo. Let's take just 1 minute. Okay, let's continue. So, vertigo. Background, differential diagnosis, and evaluation. We're going to go quickly over vertigo because we need to give time for some questions for people who have. So the first thing that comes to my mind whenever I talk about vertigo is the term dizziness. And we encounter this so much in the emergency department. يجيك المريض ويقول لك أنا دايخ. ويجي مثلا الجونيور ريزيدنت ياخذ history ويرجع ويقول patient is complaining of dizziness. And I really don't like this because you have to يعني classify dizziness. هل هي vertigo؟ هل هي pre-syncope؟ هل هي unsteady gait؟ or generalized fatigability? So try your best to categorize dizziness into these categories لأنه each one has different approach. يعني vertigo has a different approach than pre-syncope, which has different approach than unsteady gait, which has different approach than generalized fatigability. So vertigo by definition, it means the sense vertigo by definition, it means the feeling of sensation related, the feeling of spinning related to space. How can I ask this and how can I differentiate the type of dizziness? So the way I do it انه اسال المريض واقول له تشتكي من ايش؟ يقول لي دايخ. ممتاز. اقول له دايخ يعني الدنيا بتدور فيك؟ يقول لي لا. So this is not vertigo. اقول له دايخ يعني حسيت نفسك كانه حيغمى عليك بس مسكت نفسك؟ يقول لي لا. So this is not pre-syncope. اقول له والله دايخ يعني لما تيجي تمشي تحس نفسك ما انت متوازن؟ يقول لي ايوه انا this is unsteady gait. او ممكن يقول لي ممكن يقول لي لا، فاقوم اساله دايخ يعني حاسس نفسك فتران وخملان طول اليوم؟ يقول لي ايوه معناها generalized fatigability. So you can somehow differentiate dizziness into these categories if you tried. And again, it's very important to do that لانه each one has different approach. So when we talk about vertigo, we're basically talking about a peripheral cause versus central cause. And remember, in vertigo, central causes are critical, and we're going to go over them. So peripheral causes, the common one are benign positional paroxysmal vertigo, vestibular neuritis, Meniere's disease, acute otitis media. Now, rarely you can encounter someone who's complaining of vertigo because of perilymphatic fistula, vestibulotoxic medications, and acoustic neuroma. Now, in general, peripheral causes are benign. What we really care about are the central causes. Central causes, we're talking about a vertebrobasilar artery insufficiency, cerebellar stroke, or brainstem stroke. And rarely it can be a manifestation of an infection like meningitis or encephalitis or demyelination as well. So how can I differentiate between central and peripheral vertigo? How can I differentiate between central and peripheral vertigo? First of all, we have our history. So the onset is very important. So peripheral vertigo, the onset is usually sudden. The attack is usually very severe. It's usually intermittent. So it's not continuous. It lasts for a couple of hours and rarely a couple of days. The direction of nystagmus is also important in peripheral vertigo, as it's usually torsional and upbeat. And we have a video for that to make it a little bit easier. The effect of head positioning in peripheral vertigo, usually this is the movement of head induces vertigo, or even worse in vertigo. Usually peripheral vertigo, there is no associated neurological deficit, so no weakness, no cerebellar signs or symptoms. And usually peripheral vertigo is associated with either tinnitus, like in Meniere's disease, or hearing loss in labyrinthitis. On the other hand, central vertigo, usually gradual, but sometimes can be sudden as well. Usually it's mild and moderate, definitely less severe than peripheral vertigo. The duration of central vertigo usually weeks to months, and it's continuous. It doesn't come and go. No, it's there all the time. And this is one of the hallmark of central vertigo. The direction of nystagmus, usually for central vertigo, it's vertical or rotatory nystagmus. Usually, when you move the patient's head right and left, it has little change, but it can worsen with head position. Central vertigo is usually associated with neurological symptoms, especially cerebellar examination will be abnormal. We're talking about the nose to finger examination, alternating hand examination, heel to shin, or the gait. And usually central vertigo is not associated with any auditory symptoms. But keep in mind, sometimes central vertigo can present with auditory symptoms as well. So again, this way will help you differentiate peripheral from central vertigo, but it's not really definitive. يعني at some points you will have someone with picture of peripheral vertigo even though he's complaining of a central cause. So there is an area of overlap. طيب, how can I differentiate this more? We have something called the Hintz exam. So the Hintz exam stands for head impulse, nystagmus, and test of skew. So the Hintz exam, it's more sensitive than CT and early MRI, especially lateral medullary or pontine stroke. But it is operator dependent. So if you do it correctly, you will be better than a CT and even better than an early MRI. So you have head impulse, nystagmus, and test of skew. So I have a video, not long, inshallah, yani we have time for it. Can you hear the video? ولا? Can someone please answer? Okay, so apparently there is no sound. So let's go to the table again. So the head impulse, basically you hold the patient's head between your hands, and you ask the patient to look directly at you, and you jerk the head right and left. So if you have a corrective saccade, if the patients, when you turn the head right and left, if the patient cannot follow with you correctly, this is an abnormal head impulse. And an abnormal head impulse is reassuring لأنه ماشي مع البريفرال فيرتايجو. المشكلة لو كان الهيد امبلس نورمال، يعني المريض لما احرك راسه يمين يسار مركز معايا تمام، هنا ابدا اخاف لانه هذه one of the signs of central vertigo. لكن لو اني قاعد احرك براس المريض يمين يسار وبشوف قدامي زي النستاغمس نسميها corrective saccade, this is actually reassuring. The second thing اني اشوف النستاغمس. طبعا usually you ask the patient to focus on one point, or better to tell the patient to look right, left, up, and down. Now, if you have a unidirectional horizontal nystagmus, يعني عندي unidirectional horizontal nystagmus يعني عندي nystagmus على one side only. Again, this is reassuring لأنه it goes with peripheral vertigo. لكن لو كان عندي vertical nystagmus، أو لو كان عندي rotatory nystagmus، أو كان عندي horizontal nystagmus لكن bilateral, I get a little bit concerned. Finally, we have something called the test of skew. Now, the test of skew, I cover the patient's eye and I uncover it. And I notice if there is any deviation ولا لا. If there is no deviation, this is good. That goes with peripheral vertigo. But if there is deviation, this is not good because it goes with central vertigo. Again, I'm going to send you the lecture, and hopefully at that time you can see the video. Or I can send you the link later on for this video. It's very, very important to know how to do the Hintz exam. Again, Hintz exam, it's even more sensitive than CT and early MRI if done correctly. So please familiarize yourself with Hintz exam. Whenever you have a patient complaining of vertigo, please do the Hintz exam. So this is a long approach for vertigo. but due to the short time, I think we can finish. So thank you so much, everyone, for staying with us. If you have any questions, please don't hesitate. I will stay until I answered every question you have. So please fire away. طيب. طيب تركي الحساني كيف if someone can unmute people صراحة I'm not sure how to do it. So
اسمعني يا دكتور.
Okay, تركي الحساني. والله
دكتور
تركي I don't know how to unmute you, so I'm really sorry يعني if you can. No, I can't hear you.
Okay.
I don't know why, but I can't hear you.
Dr. Ahmed, you can proceed for the question. Already, you can see the
I will
screen.
just go over the questions I couldn't answer before. So someone asked, so can the stroke result from any accident hit to the brain directly? Yes, if you have bleeding, if someone hit your head and you have a bleed, the bleed will compress some area of your brain and it can cause stroke. So someone asked, why don't we restrain them? I think you're talking about seizure. So again, we don't restrain them because we don't want to cause any more trauma or any more injuries. If you restrain someone and he's moving against you, you could fracture a bone, especially if the patient is petite and very small, or you could even dislocate their shoulders. So please don't restrain them. Can we use suction during seizure? Definitely, but be careful. Don't suction blindly and don't go too deep because you don't want the patient to gag and vomit. So someone asked, should I turn the patient to the side even if he's not vomiting yet? Definitely. So the thing is, you want to prevent aspiration. فما ينفع استنى لما يحصل له vomiting ويحصل له aspiration وبعد كده الفه. فلا انا من بدري احطه على جنب واريح نفسي. Someone is asking, do we give benzo to the first time seizure? Definitely. If someone is seizing, the first line is always benzo, except لو كان hypoglycemic. Someone is asking, how can we differentiate orientation and consciousness? So consciousness, it means the level of awareness. And orientation, it means the patient is aware of the time, place, and person. يعني ممكن البيشنت يكون conscious صاحي بس مضيع، مو عارف هو فين، مو عارف ولده اللي جالس جنبه، مو عارف احنا صباح ولا ليل، فهذا he's conscious but he's disoriented. لكن لما نقول لك unconscious معناها أو sleepy or drowsy or obtunded معناها إنه البيشنت is more toward unconsciousness، يعني الآدمي نايم واحتاج أصحيه كل شوية. Someone is asking, where can I put the lecture? Honestly, I'm not sure. Maybe I can put it on Twitter or something. But definitely, if anyone wants the lecture, I'm more than happy to
We're
share
gonna
it with
upload
you.
it, دكتور أحمد الله يعطيك العافية. كل الليكتشرز راح نوصلها
If
لهم، كل
anyone
المحاضرات.
I'm trying to unmute people, but I really don't know how. So if anyone has any questions, please fire away.
دكتور أحمد، تشوف الشاشة قدامك واضحة الكويشنز؟ يبدو لنا وصلنا للختام. الله يعطيكم العافية جميعا، إن شاء الله نشوفكم غدا بإذن الله. شكرا لوقتكم، شكرا لحضوركم، الله يعطيكم العافية إن شاء الله.
الأسئلة طيب كيف الأسئلة؟ Q&A دي شفتها معلش. طيب طيب نرجع من فوق. طيب related amnesia with stroke. I'm not sure about the question. طيب someone is asking كم الوقت between the two seizure في status epilepticus regardless of the time. يعني إن شاء الله جاته seizure دحين وقعد post ictal state 3 ساعات وجاته seizure تانية it's a status epilepticus، لكن جاته seizure وجاله post ictal وصحي وفاق وصار conscious alert oriented ودخل في seizure تانية حتى لو within 30 minutes it's still not status epilepticus. So the definition is one seizure lasting for more than 5 minutes أو يكون عندي at least 2 seizures and the patient did not regain full consciousness in between regardless of the time. So someone is asking how can we differentiate between myoclonic and simple focal seizures? So this is a very difficult question. Honestly, in the emergency department, there is limited tools that we can use to differentiate between both. Usually we refer those patients to the specialized people to do EEG and more advanced imaging like MRI. So in the emergency department, there is it's really difficult to differentiate between myoclonic and simple focal seizure. So regarding magnesium sulfate in eclampsia, yes, I would definitely give the dose you wrote here, and it is enough. So how fast can we give it? Usually within 20 to 30, and usually over 20 to 30 minutes. Yeah, so someone asked, could you repeat again what is the 6th vital sign we need to check? RBS, glucose, سكر. This is the 6th vital sign. يعني حرام انه انا يجي patient seizure واقعد اتعافر معاه نص ساعه وبنها يطلع هايبوغلايسيميا. حرام يجيني patient جاي بلاتراليزيشن واقول ستروك واعمل activation للستروك كود ومش عارف ايه ويطلع هايبوغلايسيميا. So the 6th vital sign is blood glucose. So someone is asking, do we need to load the patient in ED? Well, it is preferred. Yani if someone presented with seizure, and this is the same semiology as always, and he's telling me he's not been taking his phenytoin, of course I can give him his phenytoin to discharge him home. So why not? So someone asking regarding the dose of levetiracetam. Well, it's 60 milligram. Hello? Can you hear me? ايوه انا عارف، هي في الغالب المشكله من عندي. الغالب المشكله من عندي. I do apologize. I don't know what's the problem. So regarding the dose of levetiracetam, it's 60 milligram per kg. Maximum dose 4,500 milligram per dose. تمام. Second question is in encephalopathy from alcohol. First, give thiamine or dextrose and why? Give both. تمام. طبعا classically بيقول لك give dextrose first, then give thiamine. It doesn't matter. The most important thing is to give both. But I don't know what's the problem and why I can't hear any of you. طيب, can someone talk? ايوه
تسمعنا دكتور؟
اخيرا
الله
yes.
الله، اللحظه هذه اللي انتظرها من اول اللقاء يعني
يا
صراحه.
الله يا الله I do apologize يا أخي.
لا مو مشكلة. أنا النهاية عندنا الأسئلة ذي كملها يا دكتور، بعد نحن نكمل إن شاء الله معك. آخر سؤال.
أي واحد حق الانسيفالوباثي؟
أنت الحين
والله لا
خلصت.
أيوة. If we don't have TDM, what do you mean by TDM? drug level. طب قول لي drug level يا أخي، لا تصعبها كده علي. طيب if you don't have drug level and patient having seizure, same semiology but unprovoked and patient taking his medication, can we discharge him? نرجع نقول if the patient regained his full consciousness, it's the same semiology, I can discharge him home. بس أهم حاجة ما يكون في post ictal. يعني he started to seize, I gave him the medications benzo ولا whatever and the seizure stopped ودخل في post ictal. إذا لسه في post ictal I cannot discharge someone in post ictal state لأنه a prolonged post ictal state by itself indication for further investigation. لكن لو البيشنت رجع to his normal level of consciousness وقال لي this is the same semiology, same as always, أموري كويسة, I can discharge him home even without the drug level. طيب any more questions? طبعا عبد السيد كاتب نعتذر للجميع عن بعض المشاكل التقنية. والله يا عبد المشكلة من عندي معلش، دوبي عدلتها خلاص.
شكرا يا دكتور، الله يديك ألف عافية على المحاضرة اللي أكثر من رائعة هذه.
عفوا والله بالعكس أنا مبسوط جدا و I'm really proud و happy و honored إني أكون وسطكم وأقدم محاضرة زي كده، وما شاء الله تبارك الله يعني كل الناس دول they are interested، وأنا عارف إنها إجازة يعني for people to attend something like this in their يعني own time. I really hope that each and every one of you will succeed and will be something extremely special. If you need anything, we're always here. We're always helping, inshallah. And please don't hesitate to ask anything, anytime, anywhere. طبعا انا حكون جالس هنا لين ما كلكم تخرجوا، عشان لو واحد عنده اي سؤال ان شاء الله ما نقصر معاه.
ما تقصر يا دكتور، الله يديك الف عافيه.
الله يعافيكم. طبعا also keep in mind that هذه ما هي كل ال neurological emergencies، يعني في اشياء ثانيه كان مثلا عندك الهاي اي سي بي، السباينال كورد emergencies ما الحين نتكلم عنها، سو spinal epidural abscess، spinal epidural hematoma، الكودا equina. بس للامانه لما يعني considering the time I think انه هذه هي اهم neurological emergencies and the most common. يعني كودا equina ما راح تشوفها كل يوم، لكن سيجر لو اشتغلت في اي مستشفى عام حتشوفها كل يوم. تمام، فهوبفلي انه الاشياء هذه هي الموست common. Hopefully you will be more confident and more comfortable dealing with any of them from now on.
اظن يا دكتور احمد الله يديك العافيه، وصلنا الى نهايه اللقاء. لو عندك اي اضافه انت حاب تضيفها غير الاسئله او اي شيء ثاني تفضل الان.
لا والله يعطيكم العافيه، ما عندي اي شيء اضيفه، شكرا جزيلا. وللامانه يعني شغل متعوب عليه، فشكرا جزيلا انكم سويتوا الكورس هذا. Thank you so much and thank you so much for inviting me.
الله يديك العافيه.